Good afternoon and welcome to our virtual program, Healthy Weight, Healthy Lifestyle. We are very grateful to have Dr. Michelle Maresca, Dr. Mariana Nicoletta, and Dr. Dina Arumagam with us today. A little bit about our speakers. Dr. Mariana Nicoletta is a pediatric endocrinologist and is board certified in obesity medicine, who provides specialty care for multiple acute and chronic endocrine disorders. This includes diabetes, pubertal development, growth, and thyroid disease. Dr. Nicoletta does have a particular interest in obesity and weight management, as well as type 2 diabetes, and works closely with a team of nutritionists and diabetes educators to provide the best care for her patients who may be struggling with weight or their diabetes management. In her spare time, she enjoys doing activities with her family and kids and cooking new recipes. Dr. Michelle Maresca is board certified in pediatrics, pediatric endocrinology, and obesity medicine. She received her undergraduate degree from Villanova University and her medical degree from Robert Wood Johnson Medical School. She completed residency in pediatrics, followed by a weight management fellowship at Nemours A.I. DuPont Hospital for Children and fellowship in pediatric endocrinology at Columbia University. She has served on the pediatric committee of the Obesity Medicine Association for 4 years now and is the lead for advocacy on this committee. She's a member of the advocacy committee for the Obesity Medicine Association, as well as the medical director of the Adolescent Bariatric Surgery Program at Joseph M. Sanzari Children's Hospital. In her spare time, she enjoys singing, exercising, and spending a lot of time in the car with one or more of her three kids. Dr. Dina Arumagam is a board certified gastrointestinal surgeon who is an expert in minimally invasive laparoscopic, robotic, and bariatric surgery. Dr. Arumagam has vast experience in a wide range of inpatient and outpatient procedures. You will find Dr. Arumagam to be attentive, caring, kind, and knowledgeable in formulating a customized surgical plan that best suits each patient. Prior to joining HMH, Dr. Arumagan has served many roles as a leader, researcher, and volunteer in the medical field. She has been an instructor at Hackensack Meridian, Jersey Shore University Medical Center, Department of Surgery, as well as an assistant professor at Hackensack Meridian School of Medicine with extensive research experience in a multitude of general surgical diseases, but her interests focus on improving outcomes after bariatric surgery. Her goal is to provide safe and excellent care for all of her patients while using the most up to date tools and techniques available. She is currently a member of many societies, including the American College of Surgeons, Society of American Gastrointestinal and Endoscopic Surgeons, American Society for Metabolic and Bariatric Surgery, and the Obesity Medicine Association. So, with that, I'd like to thank you, doctors, for joining us today. And at this point, I'm going to turn it over to you, Dr. Maresca.
Thank you for the introduction. So I wanted to start today's webinar by talking about weight bias and stigma so that while we're going through the remainder of these slides talking about how to achieve a healthy weight, we keep this in mind. This is clearly a topic near and dear to many of you, and I want you to think for a moment about why you came to this webinar. Why do we spend so much time talking about and thinking about weight? What is the first thing that came to your mind when you saw the advertisements for this webinar? For me, the first thing that comes to my mind when asked to talk about or think about weight is the stigma that's associated with having extra weight. Today, we're going to address the health concerns associated with having extra weight, but probably for most or many parents, the concern is beyond just health risk, but also how much harder it will be to go through life in general having extra weight. We know that there's an increased risk of bullying and low self-esteem. We also know that lifestyle changes are difficult for a myriad of reasons, and sometimes they're ineffective, even if you're doing all the right things. I've heard healthcare providers make insensitive or unhelpful comments to patients and families. I've also heard of patients whose complaints were dismissed as just being related to extra weight and potentially missing something else. While, of course, the goal is to promote good health, there's also an overlying drive towards thinness that seems to be valued by society. And some of this can set up unrealistic expectations and lead to disordered eating and other complications. So with all that being said, let's talk about how to define healthy and unhealthy weight, complications that can arise from having extra weight, and then discuss some tips for achieving a healthy weight with healthy lifestyle recommendations and other tools including anti-obesity medications and bariatric surgery. So when we talk about weight, it's important to take into account height as well. Someone who's very short may have a weight that seems very low, but could be appropriate for their height. And the same is true for someone who's very tall. So the BMI, or body mass index, is a good way to determine if the weight is appropriate for height. There's a very wide range of healthy body mass index. Anything 5th percentile or below is considered to be underweight. Between the 5th and 85th is considered to be healthy. 85th to 94th is considered overweight, and that would correspond to an adult BMI of 25. And then the 95th percentile and above is considered to be obesity, which would be for an adult 30. And the reason we look at percentiles rather than just the actual number in kids is because kids are still growing. And as kids grow, they tend to gain more weight relative to their height. And also, after a period of infancy, when kids start to get more mobile and walking around, their weight for their height tends to become thinner. So you'll notice this is the BMI chart. There's a little dip here in the curves that occurs between ages 3 to 5, and that's when kids tend to be their thinnest. And then in particular, as they start going through puberty, they tend to put on more weight relative to their height, so their BMI naturally goes up. Now, when it comes to obesity, or BMI at or above the 95th percentile, there's 3 different classes of obesity. Class 1 is BMI between the 95th percentile and 120% of the 95th percentile. Class 2 is between 120 and 140% of the 95th percentile, and this would correspond to a BMI in adults of 35. And then Class 3 obesity is 140% or higher of the 95th percentile. So for an adult, this would be a BMI of 40 or higher. So why do we focus on BMI? So the studies show that health risks increase when BMI is below and above the healthy range. And BMI is something that's easy to track and measure. You just need a scale and a way to measure height. But we do know that there's a lot more to BMI than meets the eye. So there is a lot more coming out even now about measuring other things such as waist circumference, body fat percentage. We know that muscle weighs more than fat, so athletes in particular have inflated BMIs. Also, where you store extra fat is important because extra fat around the abdominal area is less healthy than around the thighs, for instance. But in general, from a population standpoint, what's been found is that BMI is a pretty good marker. So the AAP is recommending that we continue to use BMI. However, on an individual basis, of course, it's important to look at these factors. And we want to avoid putting too much emphasis on weight because it can lead to negative self-esteem and even disordered eating. So you want to promote a healthy relationship with food, positive self-esteem, good heart health, prevent obesity-related complications. And then in particular for kids, it's important to balance weight gain so that there's good growth. So not enough weight gain, they're not going to grow well in height, but too much and it can actually cause them to stop growing a little bit earlier. So now I'm going to turn it over to Dr. Nicoletta to discuss some complications that can occur from having extra weight.
Thank you. So we become concerned with, with obesity, especially in younger children, because obesity affects multiple organs in our body. Specifically, it affects, as Dr. Maresca said, our psychosocial in regards to poor self-esteem, depression, in the development of eating disorders. It could affect the cardiovascular system in the development of hypertension and elevated cholesterol. It could affect the pulmonary system in regards to sleep. Patients can develop sleep apnea or have significant asthma due to the weight. The endocrine system specifically in regards to the development of type 2 diabetes that we are seeing in younger children more, where years ago it was not as frequent in younger kids. Next slide. So what are some of the warning signs? So there are some things that we would take a look at in regards to if obesity is pathologic and if it's something that is more than just what kids are eating. So if there's a continued weight gain with lack of growth, so if children are having this rapid weight gain, but their growth is slowing down or their growth is decelerating and they're still in their active growing phase, meaning they're not done with puberty and things like that. That's a concern, and that's something that should be looked into. Other symptoms that may be associated with weight gain is if the weight gain is rapid, if kids are very tired, they're having to nap more frequently, if there's hair loss, if there's dry skin, that is something that should be looked into. Certainly, if there's abnormal blood work, so if pediatricians, just do routine labs and there's a concern with elevated cholesterol or blood sugars, or even, with obesity, there can be abnormal liver enzymes. That is important to get further looked into. And certainly the mental health concerns is an important reason to, to take the steps for helping children with obesity even further. Next slide. So, what are some of the benefits of eating healthy? Having that balanced diet is definitely associated with better concentration and the ability to focus more. And you're eating more proteins and healthy fats, as opposed to processed foods or carbohydrates. Those foods tend to make you tired after eating them. So, proteins and fats certainly help with better, concentration and the ability to focus. Certainly helps with growth in children. The prevention of overweight, because if we're eating foods that are healthier and are filling us up more, we avoid eating again. So in that case, if kids are just snacking on unhealthy options, they tend to be hungrier sooner, and that could lead them to eat more. And also the prevention of chronic disease. So a lot of these processed foods, are also linked to some chronic diseases. Next slide. So when we eat, it's all about balance. Our food is broken down into carbohydrates, proteins, and fats. Carbohydrates, tend to excess carbohydrates tend to lead to excess calories and can lead to increased energy stores, um, as opposed to proteins, which most proteins are metabolized into energy, and it helps build muscle cells and compounds, as well as certain fats that are also help build those muscle cells and compounds. So it's a busy slide, but it's just to show that it is all about having these balanced meals, and what the important food distribution should be. Next slide. So how do we gain fat? So we have a certain amount of calories that we're eating, and if we are eating more calories than we are burning, we are going to gain. We are going to gain that fat. And we're going to put on the weight. If we're taking in those excess calories, or daily calorie intake and not moving, then the weight's really not going to change. And I put, this slide is here to show that little changes are significant when we're discussing weight. If you just look at, someone who's not eating a healthy diet and they drink 1 can of regular soda a day, that could equal 1 pound of weight gain per month. where a patient who may have a healthier, making healthier choices, and they're walking for 20, 30 minutes a day, that could lead to 1 pound of weight loss per month. So these little changes are significant when we are discussing weight overall. Next slide. So portion sizes have certainly changed over the years. When we look at a bagel 20 years ago, it's mostly doubled in size, compared to what it used to be. So, you know, our even though we may be eating the same amount, the same food product, the portion controls are bigger. Things are supersized, and so you are taking in more calories. Next slide. So one of the things that we like to use as endocrinologists and pediatricians and nutritionists is My Plate. So My Plate is a good way to focus on portion control and balanced meals. It's very easy to use, and it reinforces these nutrition guidelines across all ages. And it's available on website choosemyplate.gov. Next slide. What's also an easy rule to follow is the 5-2-1-0 rule, where we focus on 5 or more fruits and vegetables a day, 2 hours or less of screen time, 1 hour or more of physical activity, and 0 sugary drinks. So increasing our water intake. So starting healthy eating habits at a very young age is beneficial. Starting from infants who are breastfeeding, breast milk composition better fits an infant's needs, and it also contains substances that can help regulate their appetite and fat cell development. And they have the ability to decide when they don't want any more. So they can self-regulate their intake as opposed to finishing the entire bottle, or finishing, or as older kids, finishing what's on your plate. Not introducing juice at an early age, and also introducing vegetables first and early as opposed to the sweeter options such as fruit. So choosing different vegetables daily and repeating that exposure to those vegetables, because sometimes babies may not take a liking to it, and you may think, oh, they don't like it, so I'm never going to give it to them again. But if you expose them to that same vegetable day after day, eventually they will start to eat it, and that just kind of broadens their spectrum on foods that they will eat down the road. Next slide. So what are some tips for parents? So encourage your children to eat breakfast daily. So that's important because, then kids are hungry. Sometimes they skip breakfast and lunch, and then they're starving when they get home, and just tend to overeat at that point. So trying to aim to eat their meals. Aiming for regular meal times, eating with your children, no electronics during meals, no phones, no iPads, no TV. Give your kids chores. So definitely that can help engage them in physical activity, as far as, if they're not in an organized sport, just give them chores to do around the house. Go for walks with them, play basketball with them. And of course, limiting screen time to 2 hours or less each day. Next slide. Some other tips is keeping healthy foods in the home. So having that available, cutting up fruit or vegetables and having it available in the fridge for easy access is helpful. Avoid buying any sugary beverages. Being persistent with having them try new foods. Again, just if you offer those foods every day, eventually kids will start to try them and eat them. Learning about portion control, getting your children involved in preparing foods and buying the foods, taking them food shopping. Oftentimes that's helpful because they'll want to try those things that they selected. And encouraging kids, most importantly, is that it's about living a healthy lifestyle and it's not about being overweight. That is really the key point here is just we want kids to be healthy. Think, okay.
So, as a parent, I can completely understand that we get frustrated with our kids when we see them making choices that aren't the best. But unfortunately, sometimes it's beyond our control. So, some things that we as parents need to keep in mind are that the amount of control we have goes down as the kids get older. We can only control so much. We can control what gets brought into the house, that is, until the kids have money and can buy their own food. We can set limits, but we can only set limits to a certain degree. And it's difficult and not necessarily recommended to force a child to eat a certain amount of food or a particular food. When it comes to choices, we need to be realistic and not expect them to make choices that require insight because that part of their brain hasn't developed yet. So we shouldn't expect them to choose broccoli over a cupcake. Some kids may, but the majority will choose the cupcake. So rather than getting frustrated with them for choosing the cupcake, maybe present a different choice, such as having broccoli or green beans. And it's not that they can't ever have the cupcake, just try to keep a habit of balancing healthy food with occasional treats. And it's also important to honor the child's hunger and fullness signals. And if those signals aren't working appropriately, then talk to your healthcare provider for some other strategies. Then when it comes to teens, of course, food is social for all of us. When kids and teens go out with friends, it almost always evolves around food in some form or another, and it's usually not the healthy options. But if you think about it, food is social for all of us. Birthday parties, holidays, family dinners. And it's important to remember that, particularly because we want our kids to develop a healthy relationship with food. And this acknowledges that while the primary goal of eating is to provide nourishment to our bodies, it's not that simple. I've also seen a lot of parents get really frustrated because they feel that their child or teen doesn't care about their weight or their health. But I would say that more than likely they do care. It's just that they probably don't want to talk about it because it's something that's not so easy to talk about. And we have to try to find line because this is a really vulnerable time for them. And we don't want to promote poor self-esteem or body image, but also want to encourage lifestyle modifications. So my recommendation would be to approach it in a non-judgmental, non-blaming way. And we know that obesity is a chronic medical illness, and there's multiple factors that go into the development of obesity. So I would recommend approaching them with, hey, look, we know this isn't easy, this isn't your fault, and there's things we can do to help. So to change gears again, what if your child has the opposite problem? And what if they're not gaining enough? So I see this particularly in kids who have ADHD and are on stimulant medication, but there's other medications that can potentially lower appetite, or they just may have a low appetite or be a picky eater in general. So one way that you can easily add calories without adding bulk is to add fat to food. So as an example, putting butter on a slice of bread will almost double the calories, but you don't realize that you're eating more. And so that would be kind of the opposite for somebody who is trying to eat less calories. You'd want to look for things like that that you can easily remove without necessarily feeling like you're taking more away. A nighttime snack can be very helpful, but trying to make the nighttime snack something that has carbs, protein, and fat. Some people will use meal replacements or supplements such as Pediasure, that kind of supplement. I recommend using them at times when you ordinarily wouldn't be having another meal. So for a kid who doesn't have time to eat breakfast or wouldn't ordinarily eat breakfast, they can use a meal substitute, or you can use the meal substitute as a bedtime snack. I don't like using it as a substitute for other meals because then it takes the place of other food. And they also develop this preference for the sweet taste of the supplement. For kids who don't really like the school lunch, you can pack them a snack or pack them lunch to take to school. You also want to try to avoid having them fill up on snack foods or nutrient poor foods, because a lot of kids who have lower appetite are going to fill up on foods that aren't so nutritious, and then they're going to say they're not hungry for dinner. And then take advantage of the times of hunger. So for medications in particular, like the ADHD medications, make sure they have a good breakfast. And then whenever the medication starts wearing off, either a snack, a good dinner, and then a bedtime snack. And then there's the really sticky situation. What if your children have different health needs? So as much as possible, everybody should be eating the same food. And nobody really needs processed snack foods. I often hear, oh, it's unfair that, one child can't have it because the other one can't. But actually, it's unfair to the child who can't have that food to be seeing it, to see other, family members eating it, and to be expected to not eat it. So try to keep the off limit foods out of the house, and also try not to focus on the differences between the kids. So we know that there's no way to address every individual concern in this webinar. So I just wanted to point out that there's many resources available to fit each of your individual needs, such as dietitians, different physician specialists, behavioral health, community resources, and physical therapists. And I'm going to turn to obesity medications briefly. So why use medication to treat pediatric obesity? So we know that obesity is a chronic illness. It's not a simple matter of calories in versus calories out. And there's also many factors that affect your calories in, things that affect your appetite that are beyond our control, several factors that affect how many calories that your body burns, also beyond our control. And then things that happened even before we were born, genetics, prenatal environment. And so medications kind of help to control the factors that we can't control beyond the lifestyle modifications. We also know that medications in general are more effective than lifestyle modifications alone. Now, that's not to say that lifestyle modifications are not important or that they're not effective, but for some people in particular, it's a really helpful tool. So general guidelines for weight loss medications. Most of the weight loss medications are approved for children ages 12 and older who have a BMI in the obesity range or in the overweight range with an obesity-related health condition. You don't have to necessarily fail lifestyle modifications first. In general, when I have conversations with families, it's, I bring up that this is an additional tool that may be right for some people, but not for everyone. It can be used before bariatric surgery or even after if there's a weight loss plateau that's occurring. And likely these medications will need to be used long-term for the best outcomes, but also to prevent weight regain. There are several medications that are FDA approved for adolescents who are under 18. For purposes of time, I'm really only going to focus on one, which is the one that's the most popular and that we tend to get the most questions about, which is Wegovy or semaglutide. Phentermine and phentermine topiramate are pills that help to decrease appetite that are also very good options. And I also get a lot of questions about Zepbound or Mounjaro. This medication is not yet approved for adolescents, so I will not be talking about it today, but it is similar to Wegovy. So what is Wegovy? Wegovy is a once-a-week injection. That's what the pen looks like. The needle is hidden. It is a mimic of a protein that comes from your gut called GLP-1 or glucagon-like peptide 1 that's released after eating. So GLP-1 communicates with the chemicals in your brain that regulate your appetite. So it says that it tells your brain that you've eaten and that you're full. So it decreases your hunger. It also slows down how quickly your stomach empties so that you stay feeling fuller longer. What a lot of people have said to me is that it decreases the food noise or decreases their cravings. There are 5 different doses of the medication. You start at the lowest dose, and then after being on the medication for a month, you can go up on the dose, and each dose you can increase after a month of taking it. The most common side effects of the medication are related to the belly: nausea, belly pain, vomiting, egg burps or sulfur burps. Those are the most common that I've heard. Diarrhea and constipation are also possible. Less commonly, headaches and dizziness. Very rarely, pancreatitis. And also gallstones can happen, which can happen really from any cause of weight loss. Some cautions if you're considering taking this medication. If you already have slowed stomach emptying or slow intestinal movement, you want to be really careful, and this might not be the right medication for you. If you hear the advertisements, they always talk about medullary thyroid cancer. This developed in rats, but it's actually really important to talk to your healthcare provider about this if there is a family history, because it may mean that your child should also be screened for this condition, completely unrelated to the medication. And then lastly, I just wanted to spend a minute talking about the compounded form of semaglutide. So you may have seen advertisements. Weight Watchers uses it. I saw advertisements for Hims and Hers and other, cheap versions of this medication. So unfortunately, not every insurance company pays for this medicine, and it costs about $1,000 a month if the insurance isn't paying for it. So people are looking for less expensive alternatives, but because the medication is patented, it's actually, you can't have a generic version. So when there was a shortage, some pharmacies were able to compound it, but it's not regulated by the FDA. We don't know if it's safe because a lot of the pharmacies are adding things to it. We don't know if there's safety checks. So I just recommend being very cautious and trying to avoid compounded versions. And then lastly, I just wanted to show kind of the results that were, this is the trial that led to the approval of this medication for adolescents. So in the trial, there were two groups. There was the group that received the medication, and there was a placebo group that was just lifestyle modifications alone. So the average weight loss after 68 weeks of treatment, the average BMI loss. I use weight and BMI interchangeably here, but it's actually BMI because the kids were still growing. But the average loss was 16.1% in the treatment group versus a gain of 0.6% in the lifestyle-only group. 73% of patients in the semaglutide group lost 5% or more of their BMI, versus only 18% in the control group lost 5% or more of their BMI. And those who took semaglutide also had more reduction in their waist circumference or their unhealthy abdominal fat. Hemoglobin A1C, which is a screening test for diabetes and a measure of your average blood sugar over 3 months. Their cholesterol and triglycerides lowered, except for their good cholesterol. And ALT, which is a marker for fatty liver. And just to look at it in graphic form, on the y-axis is your percent change in BMI, and then on the x-axis is time, and this is the semaglutide group. So you can see that at all the time points, they lost more BMI than the placebo group, which didn't change a whole lot. And then lastly, this is the percent of people who lost different thresholds of BMI. So I just wanted to point out that over half of the people in the study lost at least 15%, and 20% or 37% lost 20% or more, compared with the placebo group where it's only 5 or 3%. So now I'm going to turn it over to Dr. Arumugam to talk about bariatric surgery.
Hi, everybody. Thanks so much for coming today. Sorry, my video is not working. I apologize for that, but hopefully you can hear me all right. So I just wanted to give you just a brief summary that we do have actually 2 weight loss programs for adolescent bariatric surgery up north at Hackensack, as well as at Jersey Shore Medical Center. accredited programs that offer bariatric surgery for adults as well as adolescents, and as well as certification in obesity medicine, so non-surgical options for weight loss. What these programs offer really are supervised weight management programs that really cover kind of the whole spectrum of obesity management for both adults and adolescents. And we really focus on a team approach, like was mentioned before, to get optimal results for patients. So this includes several disciplinary teams within pediatrics like GI, endocrinology, nutrition, behavioral specialists, as well as the surgical team. We have nurse coordinators who help as well. Our focus really is on safe and effective weight loss through surgical and non-surgical means. Next slide. So, we already talked a little bit about this stuff already. So, we know that obesity and extra weight is multifactorial, and that's why we treat it with multiple different things as well. Diet, exercise, behavior modification, and weight loss medications we've already talked about. The question is, when does surgical options for weight loss become a possibility as well? And just like medications, it's not for everybody. Oftentimes, especially in the adolescent group, we tend not to go straight for surgery. We prefer to try all these other things first over the course of months or even years to see what kind of progress we can make in our patient's weight prior to considering weight loss surgery as an option. Next slide. We do use our national pediatric guidelines to help us treat obesity. Ultimately, prevention is key, and some of the recommendations that were made by Dr. Maresca and Dr. Nicoletta really help with this. What we've also concluded is that weight loss surgery is a safe and effective option for the adolescent population. And non-surgical options often tend to be insufficient to achieve adequate weight loss to then affect health in a positive way. For some patients, weight loss surgery may actually be the best option for significant weight loss, and I'll go into the criteria for that in just a couple of slides. The goal ultimately is to reverse the comorbidities that are involved with having excess weight, to achieve overall wellness and good health, and also to remove the stigma that's associated with obesity and also the surgical management of treating childhood obesity. So the reason weight loss surgery is so beneficial for a large majority of patients who complete surgery is because of the medical conditions that we see improved after surgery. So we know that excess weight, overweight, obesity are associated with several different medical conditions. Heart disease is one of those. What we're finding is that after weight loss surgery, patients have significant improvements in all measures of heart disease health within 2 years of surgery. So these are things like looking at blood work that shows cholesterol levels, inflammatory markers, insulin resistance or prediabetes. We're seeing improvements in blood pressure as well. And the weight loss that happens has an effect on these things actually very quickly after surgery. Is another medical condition we see often in childhood obesity. It's associated with increased cardiovascular risk, both during childhood and as well as a predictor of risk later into adulthood. And what we're seeing is that after weight loss surgery, within 3 years, we're having actually remission, so complete cure of prediabetes in 76% of patients, and resolution of type 2 diabetes in 95% of patients. So this is essentially showing that weight loss surgery can cure diabetes. As far as blood work goes, we're seeing decreased hemoglobin A1C levels, which is another test that tells us about insulin resistance and diabetes in those who have surgery compared to those who were actually treated medically for their diabetes. And resolution of insulin resistance is better in adolescents after weight loss surgery compared to adults, as well as coming off of their diabetic medication. So we're seeing improvements in diabetes for adolescent patients alone, we're seeing that better than those who get treated medically for diabetes, and we're actually seeing improvements in adolescents compared to adults who have weight loss surgery. So really huge benefits in treating diabetes after weight loss surgery in the adolescent population. Sleep apnea is found in about 1/3 of children who are diagnosed with obesity, and it causes really significant decreased quality of life, health-related quality of life for those patients. We're seeing significant improvements or even resolution of sleep apnea after weight loss surgery in the adolescent population, which is something similar we find in adults. Non-alcoholic fatty liver disease or liver fibrosis happens in anywhere from 10 to 30% of patients who are undergoing weight loss surgery. This is true for adolescents as well. And we're finding that weight loss surgery is more effective in reducing the progression of liver disease and sometimes also resolving mild liver disease when compared to just lifestyle changes alone in the adolescent population. We've touched upon the fact how excess weight really affects patients emotionally and socially, and weight loss surgery has also shown to improve quality of life, both health-related and weight-related in the adolescent population. Also, we see improvements in mental health, specifically with regard to depression and anxiety, and again, we see these changes happening within a year or a couple years after surgery. So the reason that we see all of these significant improvements in medical conditions after weight loss surgery in both adolescents and adults is because we're seeing significant weight loss changes in these patients. So over 5 years, on average, patients drop about 14 BMI points. So if their starting BMI is about a 40, we're seeing them come down to a BMI in the high 20s typically, which is actually getting them out of that obese category and overall making them healthier. This equates to about a 25 to 30% total weight loss in patients who have weight loss surgery, and over that same time frame of 5 years, we're actually seeing patients that don't have weight loss surgery actually gaining weight during that time. Most of the weight that we see patients lose initially is maintained even 10 years or longer after surgery, and the results are actually similar to those results we see in adults. So there's a question about whether this is something we should do for children and their teens. Wait until they're older to put them through surgery for weight loss. Studies show that that's not the case, that their results are actually as good, if not better, as far as weight loss goes and medical conditions being improved goes in the adolescent population. So of course, this is a surgery. We worry about risk. In general, the overall risk of weight loss surgery these days when we do surgery laparoscopically with little incisions is very, very low. Major complications happen 1% to 2% of the time. Those are things like significant bleeding, reoperation, or leakage along the area where we're cutting the stomach. The complication rates in general are very low, and again, they're equivalent to complication rates that we're seeing in the adult population having the same surgery. So overall, just to kind of summarize, what we're seeing is that weight loss surgery in adolescents specifically causes significant weight loss that is sustained years later. This results in improved health for those patients and oftentimes resolution of medical conditions that are associated with the excess weight. And overall, it is a safe treatment option for patients. So as we mentioned earlier, not all treatments are appropriate for everybody. So as far as surgery goes, we do use the BMI to help us define who is a potential candidate for surgery. As Dr. Maresca reviewed earlier, we're looking at those that have class 2 or class 3 obesity. So this has to do with the growth charts or BMIs that are 35 or above. BMI that's 35 to 40 with one comorbidity such as high blood pressure, diabetes, reflux, sleep apnea, they would qualify for surgery. Anyone with a BMI equal to or above 40 would automatically qualify if they are otherwise healthy. Puberty status or growth. So if children haven't finished growing yet, these are not factors that would preclude surgery. There are differences in insurance requirements for surgery, so it's kind of case by case basis. But really, what we're looking at is BMI and health conditions. Most surgery that we do these days, I'd say almost 99% of surgery for weight loss is being done minimally invasive. That means we use small incision surgery. This has really changed the recovery time, pain, complications related to surgery. We have different options for weight loss surgery in general, some that restrict the caloric intake by making the stomach smaller, and some that actually change the way our body absorbs and digests calories. That has actually to do with rerouting the intestines. For adolescents, really worldwide and in the United States, the most common weight loss surgery that we do is the sleeve gastrectomy, which is a restrictive operation, and it involves cutting the stomach. We actually remove about 70 to 80% of the stomach from the body by making it smaller than when you eat. You feel full very quickly, and that reduces the caloric intake. It also has an effect on hormones responsible for hunger. That gives an additional weight loss benefit, and as I mentioned, very safe and effective surgery. Finally, just to, kind of make the point obvious or focus on this point, weight, kids' health, this really should be something that the whole family is involved in. For minors, parents are giving consent for surgery, but we really do want the parents and the children to be involved in these decisions. Having a good understanding of the risk of lifelong obesity and the health issues that can go along with that, but then also, the risks and benefits of the surgery themselves, and that surgery is not a quick fix. It takes work, that there are significant lifestyle changes that need to continue forever to really do well and succeed. And I think it's very important that both the patients and the families who are helping support them understand, everything that goes into it before proceeding with any kind of surgical interventions.
Great. Thank you all so very much for this wonderful presentation. If you want to forward to the next slide, we can leave up resources, and then we have a few questions that were submitted. So the first question is, how do I deal with the constant "I'm hungry"? The only way for my son not to say it is if he's glued to the video console.
So most kids may say they're hungry throughout a short period of time. Sometimes it's just out of boredom. They really aren't hungry, but they're just bored, so they'll go to the pantry for snacks or whatnot. But definitely choosing the right foods, diets that are higher in like processed foods and carbohydrates can make kids feel hungrier sooner. So, trying to add more proteins and healthy fats to their diet and to their snacks is beneficial so that they don't feel like they're hungry, just an hour or two after they eat something. Also, having them stay hydrated. So, making sure they're drinking enough water also helps with that I'm hungry, I'm hungry feeling.
Okay, great. The next question is, I have a 15-year-old son diagnosed with autism. Is it true that my son's diet is crucial for him to improve his focus and concentration? Is there a diet that I should be having him follow?
So there's no specific diet. However, in general, just eating foods that, are healthier, such as like your fruits, your vegetables, your proteins, will help kids focus a little bit more and concentrate, as opposed to other foods that, may be packaged or high in carbohydrates, where kids may feel more sluggish after eating it. Dr. Maresca does have a slide up specifically for kids, who may have autism, which sometimes does become challenging. Their diet often becomes challenging. But offering them new foods, being persistent, praising them for the new foods that they're trying, maybe giving them a reward, just having good mealtime habits and creating a schedule, and sticking to it, and then trying to sneak foods, fruits and vegetables into purees, or in other foods that they might be eating, may also be helpful.
Okay, great. What are some of the key words to help explain to younger children, like ages 9 to 11 years old, what eating healthy means? We've tried things like good fuel versus bad fuel and try to visualize them how energy can quickly go up, then quickly down, but it seems to be tough to get through to them.
So, just really, showing them the different foods, what's good versus what's healthy versus unhealthy, I think is important. Pictures are good. Actually having the foods, in front of them and saying, which choice, what would you pick? Why would you pick that? So just kind of explaining to them in that way, as in regards to what are healthier choices versus which are not so healthier choices.
Okay, great. Do you approach girls versus boys when it comes to communicating self-esteem or body image?
I can take this one. So I, there is a higher rate of eating disorders in girls, but there are a fair number of boys who also have eating disorders. So I think it's important for both girls and boys, to approach it in the same way by focusing on health, not so much body size.
Okay, great. And the last question is kind of a comment and a question. I appreciate that there are experts on here that approach weight loss management in children from different angles. Is there a consensus among the specialties about when and what option is most appropriate? Similar to how surgeons do surgery, since that is what they do, versus physicians who advocate for non-surgical interventions because that's what they know.
I think it's really important to look at the individual person. As we've alluded to, there isn't one right answer for everyone. If you look at the guidelines, there were new guidelines that came out from the American Academy of Pediatrics, which most of us in the Obesity Medicine Association or committee, the obesity medicine fields felt were long overdue, where there are guidelines and they say, to evaluate, encourage healthy lifestyle, consider medication, consider surgery. So it depends on what your individual needs are. And kind of when I'm seeing a patient for the first time, I do a whole history. I ask them about their appetite. I ask them about, like, what are their triggers for eating? Is it boredom? Is it emotion? Do they just feel hungry all the time? Or, have they tried everything and still can't lose weight despite, eating a calorically restricted diet and being very active? So the answer to all of those questions kind of helps me to guide me towards what treatment might be the most beneficial for them. Um, so I think that really the consensus is, just looking at the patient individually and finding out what option might be best for them.
Okay, great. Thank you again, Doctors Arumagan, Maresca, and Nicoletta. It was such a very helpful and informative presentation. We really appreciate you taking time out of your day to spend with us. And thank you to all of you for taking the time to join us. Please watch your email for an evaluation of the program. Please take the time to fill it out. We want to hear from you and also let you know if there are other topics of interest that you would like to see. You'll also receive the link to the recording of the webinar as well as the PowerPoint, as you may want to listen again or share it with others. It will also be posted on our website on hackensackmeridianhealth.org. We have several other parent forum webinars coming up that we hope you will join us for. On February 27th from noon to 1, we have Let's Sleep, Sleep Distractions and Adjusting to Time Change. And on March 27th, also from noon to 1, Headaches and Seizures. Please visit our website or call 1-800-560-9990 to register for either one of those and find out more information about these upcoming programs and others. Enjoy the rest of your day, everyone, and thank you again, doctors.